Welcome to the deep dive. Today, we're taking the complex, sprawling universe of psychotherapy, the ways we heal the mind, and giving you the high-level map. You shared with us a monumental body of research, a chapter drawn directly from a major psychiatric textbook, and our mission is really to distill the foundational theories, the key mechanisms, and maybe some surprising truths about what actually helps. We're wading through, I think the source said, over 400 distinct therapeutic approaches today.
That's right. It's a lot.
So our biggest challenge is finding the common thread, structuring this knowledge so, you can see the forest for the trees.
Well, what's immediately clear from the source material is this kind of core tension defining the field. On one side, you have the drive for highly specialized, structured, evidence-based, specific manuals for specific diagnoses. But on the other, there's this growing consensus pointing to the overwhelming power of common factors.
Common fact?
Yeah, these factors, things like the therapeutic alliance, the relationship, the installation of hope, providing a corrective emotional experience, these often account for more the positive outcome than the specific technique being used.
Really? More than the technique itself?
Often, yes. And the ethical argument here is pretty compelling. We should probably prioritize evidence-supported therapies, acknowledging that the trust and that shared mission between patient and clinicians are, paramount.
That really reframes everything, doesn't it? It suggests the fit matters just as much as the method.
Precisely.
Okay, let's unpack this. We should probably start at the source, the psychoanalytic roots. This tracks back to Sigmund Freud's initial kind of unexpected discovery, right? When he shifted away from hypnosis.
Exactly. That shift was crucial. The early work with the cathartic method, recovering traumatic memories, often through hypnosis, it yielded only transitory effects. Fleeting. The major breakthrough came when Freud realized that if he simply asked the patient to speak freely, the same forces that caused the original repression would resurface in the room.
In the room? How?
As resistance. Resistance against full disclosure.
Okay.
If you ask someone to speak freely and they suddenly go silent or change the subject, maybe complain about the furniture.
Yeah.
That's resistance manifesting.
I see.
That process, free association, immediately brought forth the two concepts that truly define psychoanalysis: resistance and its partner, transference.
And transference, that's when feelings toward the analyst pop up, but those feelings are actually unexpected, derived from past relationships or childhood fantasies, right? Like relational time travel.
Exactly. It's an unconscious replay. The analyst becomes essentially a screen onto which the patient projects these powerful old emotions. And the process of analyzing the transference and the resistance, what they call the working through, that's what allows for new, non-repressive ways of relating to be discovered.
Okay. Within this framework, they had to model the mind's machinery somehow. When we talk about defenses, what's the critical distinction the sources want us to remember?
Well, the main distinction is between the mature and the immature defenses.
Okay.
Mature defenses, like, say, sublimation or altruism, they allow us to express unconscious needs in socially productive or acceptable ways. They help integrate experience.
Right.
The immature defenses, though, those are what cause the most interpersonal chaos. Think about projective identification.
Projective identification?
Yeah.
Sounds complicated.
It is. It's not just projecting your anger onto someone else. It's this intense three-part sequence where you not only project an unacceptable feeling, but you unconsciously behave in a way that causes the other person to actually experience that projected feeling,
Wow.
which you then try to control in them. It's incredibly complex and disruptive.
Wait, so if you were projecting anger, you'd make the other person angry and then criticize them for being angry? That sounds exhausting.
It is exhausting. And that mechanism is really central to understanding highly volatile relationships. Ultimately, integrating all this information, the defenses, the transference patterns, the history, it leads to the psychodynamic formulation.
Okay, the formulation. And if that provides predictability about the likely course of transference, does that mean the analyst has to, get it right the first time? Or is the formulation constantly shifting?
Well, it's definitely a living document. It's not set in stone.
Okay.
The formulation is the integrated hypothesis of the patient's core problems, their character vulnerability, and the probable course of the treatment. It helps the clinician understand the patient's internal mental life, but it absolutely evolves as the patient brings new material, new experiences to light.
Got it. So we've mapped the theoretical deep end of the mind, so to speak. Now let's pivot completely to the reality of frontline care, supportive psychotherapy. This is the support pillar that often gets overlooked, maybe in favor of flashier treatments.
Yeah, and the sources are very clear on this. Supportive therapy is often the control condition in rigorous studies,
Mm,
the basic treatment against which specialized therapies are measured.
right.
And yet it is frequently found to be equally effective as those specialized treatments for an incredibly wide range of issues.
Equally effective for things like what?
Well, the text mentions schizophrenia, depression, various anxiety disorders, and even chronic medical conditions like cancers, chronic bronchitis, or irritable bowel syndrome.
It's a huge range. So what does this simple, effective therapy actually look like in practice?
It's basically conversational, comforting. It focuses on strengthening the patient's existing coping mechanisms and maintaining self-esteem. The therapist doesn't maintain that blank slate of classical psychoanalysis. The goal is simply reducing anxiety and promoting a positive therapeutic alliance.
And how long does it last?
It really varies. Sometimes just a few sessions for, say, an adjustment issue, or for major mental illness or chronic primitive personality disorders, it's used as ongoing long-term care. The text likens it to managing a chronic physical disease, like brittle diabetes.
Okay, that makes sense. Moving forward then, let's transition to the modern structured paradigm that shifted the focus, cognitive behavior therapy, CBT, developed by Aaron T. Beck. The fundamental shift here was placing our thoughts right at the center of psychopathology, wasn't it?
Absolutely. CBT focuses squarely on the interplay between thoughts, feelings, and behavior. The core model for depression, for instance, is the cognitive triad. Negative beliefs about the self, about the world or life experience, and critically, about the future.
The future.
Yeah, depressed patients often predict unending problems and pain, hopelessness.
And if we look at the opposite extreme, the inflated thoughts of mania.
The contrast really highlights how crucial cognition is. Mania is characterized by these expansive, hyper-positive core beliefs. Patients might believe, I am powerful, I am invulnerable, or I am capable of anything. And this really drives the impulsive, high-risk behavior we associate with a manic episode.
So, if the thoughts are the problem, how does CBT actively dismantle these distortions in session? It's not just telling people they're wrong, is it?
Definitely not. The key technique is guided discovery, implemented primarily through Socratic questioning.
Socratic questioning, like Plato.
Sort of, yeah. It's not the therapist lecturing. It's a guided conversation to help the patient test reality for themselves, to help them label their own cognitive distortions, and to collaboratively seek out alternative, healthier explanations for their experiences.
Okay.
And alongside that, the behavioral component is vital, especially for anxiety. This includes things like exposure and response prevention, ERP for OCD. That's where the patient is coached to confront their fear, triggers whatever makes them anxious, while simultaneously refraining from the rituals they usually use to neutralize the anxiety.
So they test whether their feared outcome actually happens.
Exactly. They learn through experience that the catastrophe they predict doesn't occur, or that they can handle the distress.
That structured approach is so focused on changing the content of the thought. But the sources also introduced the third wave of behavioral therapy, like acceptance and commitment therapy, ACT, which seems to shift the focus entirely.
It does. ACT represents a significant move away from challenging the thought content to changing the function of trying to control the thought in the first place. The goal is increasing psychological flexibility.
The psychological flexibility,
But
yeah.
by tackling the acronym FEAR.
Fear.
Yeah, FEAR stands for fusion with thoughts that's believing a thought is reality. Evaluation of experience, constantly judging things as good or bad. Avoidance of experience running from discomfort. And reason-giving, basically, rationalizing inaction.
Okay, fear. Fusion, evaluation, avoidance, reason-giving.
Right, and the ACT model suggests we counter that fear by, well, ACT. Accepting reactions and being present, choosing a valued direction in life, and taking action toward those values. A key skill here is cognitive diffusion. It's about learning to simply observe a thought neutrally, like watching clouds drift by, rather than getting hooked or engaging in a debate with it.
So not fighting the thought, just letting it be there.
Pretty much. Observing it without fusing with it.
Interesting. Now let's turn to some specialized and intensive modalities designed for really volatile relational patterns, specifically borderline personality disorder, BPD. The material names 3 specialized treatments, DBT, MBT, and TFP, and notes the scarcity of trained clinicians.
Yeah, the need for this specialization comes from the severity of the emotional dysregulation involved. DBT, or dialectical behavior therapy, developed by Marshall Linehan, is built on the biosocial theory,
Biosocial theory.
which basically suggests that an innate emotional vulnerability interacts with an invalidating environment, leading to this profound emotional dysregulation.
Okay. And to manage this, DBT sounds highly demanding. The text mentions group skills training, individual therapy, phone consultation, and a consultation team for the therapist themselves.
It is intensive, and the core intervention strategy is the dialectical strategy.
Dialectical?
Yeah, it's about pushing the patient away from rigid, polarized either-or, thinking like, I'm either all good or all bad, toward a both-and synthesis. It blends acceptance and change strategies constantly.
Okay, finding a middle ground, a synthesis.
Exactly. It helps regulate those extreme emotional swings.
And mentalization-based treatment, or MBT. How does that tackle BPD differently?
MBT focuses on mentalization,
Which is?
which is the capacity to make sense of behavior, both in yourself and in others, based on underlying intentional mental states, like feelings, desires, beliefs, that kind of thing. Under stress, people with BPD tend to lose this capacity. They can't mentalize effectively.
What happens then?
They can fall into what are called non-mentalizing modes. One is psychic equivalence.
Psychic equivalence.
This is where the internal feeling equals external reality. If a patient feels worthless, for them it's not just a feeling. It literally feels like a hard, undeniable, physical fact about the universe. There's no space between the thought and the truth.
Wow, that must make the world feel incredibly concrete and threatening.
It really can. Another mode is the teleologic mode.
Teleologic?
Yeah, where only physical, concrete actions are believed to be able to change mental processes. So thoughts like, I only feel safe if I can see you physically right now, or maybe I must harm myself to prove how much I'm suffering.
Okay, so the therapy works to restore that space for reflective thinking, for mentalizing.
Precisely. To help them understand their own minds and the minds of others more flexibly.
Let's look now at a different kind of structured, time-limited approach. Interpersonal psychotherapy, IPT.
Right, IPT. It's evidence-based and time-limited, often used effectively for depression. Its structure is very clear. It starts by formally diagnosing the patient and assigning them the sick role.
The sick role?
Yeah, this gives the patient a legitimate, time-limited exemption from their usual social roles so they can focus entirely on recovery without feeling guilty about it.
That's interesting. And what does the therapy focus on?
It focuses on one, or sometimes two, of four defined current interpersonal problem areas.
Okay, what are they?
Complicated grief,
Right.
interpersonal role disputes, which means conflicts with significant others over differing expectations, role transitions, like major life changes such as job loss, divorce, or retirement, and fourth, interpersonal deficits, which usually means chronic social isolation or difficulty forming relationships.
So very focused on current relationships and social functioning.
Exactly. That structure helps clinicians and patients focus on specific, manageable targets.
Let's shift gears a bit now to context and some emerging frontiers, starting with how therapists approach potentially very limited contact.
Yeah, the text highlights something called single-session thinking, SST.
Single-session thinking.
It's based on research showing that, well, most therapeutic change actually happens quite early in therapy. And very often, the first session is the only session a patient attends for various reasons.
Right, people drop out or maybe just needed that one contact.
Exactly. So SST is really an attitude, a mindset for the therapist to make the absolute most of that initial meeting, prioritizing immediate needs and providing resources, assuming it might be the only chance they get.
Making every session count, essentially.
You got it.
Okay, and we absolutely must talk about the integration of mind and body through hypnosis. The text is clear. It's not sleep or mind control.
Definitely not.
But it calls it the patient's alert, focused, and receptive attention, almost like the patient's gift to the process.
That's a nice way to put it. The key is that hypnosis capitalizes on an innate ability that varies in the population. We know there's a measurable trait of hypnotizability. It's distributed normally, like height or weight, with maybe 10 to 20% being highly responsive.
And does being hypnotizable matter for outcomes?
Interestingly, yes and no. The text says this trait predicts outcomes for specific conditions like anxiety, pain management, and phobias.
Yeah.
But crucially, it does not seem to predict success for addictive behaviors like smoking cessation or weight loss.
Huh. That's specific. And what happens during hypnosis?
Well, you can see phenomena like ideomotor activity. That's where a thought causes muscles to involuntarily respond almost instantly. Think about those suggestibility tests where your arms might feel lighter or heavier.
Right.
And also hypermnesia, which is increased memory recall. This capacity needs careful management, though, because the risk of creating inaccurate memories or confabulation during suggestion is significant if not done carefully.
Handle with care, then.
Absolutely.
The ultimate synthesis of this whole deep dive seems to be the connection between talk therapy and neuroscience. How does what we discuss here, these conversations, literally modulate brain function?
Yeah, this is where we move from psychological theory to actual biology. Studies confirm that verbal therapies can alter brain activity patterns. The source material mentions research specifically on CBT for OCD. It showed the expected decrease in thalamic activity, maybe less overactive sensory gating,
Okay.
but also, interestingly, an increase in activity in the right anterior cingulate cortex, ACC.
An increase in ACC activity. That means
Right.
increased self-awareness, emotion regulation.
Exactly. It suggests the act of verbal processing, of cognitive restructuring, is actually strengthening the brain's internal monitoring and control systems.
That's fascinating.
Conversely, the sources also note that the dorsomedial prefrontal cortex, DMPFC, which is key for that top-down cognitive modulation of fear, is sometimes hypoactive or underactive in severely depressed patients. This can limit therapeutic success until maybe more supportive measures build up the ego, so to speak, enough for the cognitive work to actually land and be effective.
Wow. That is a powerful connection. Our words, our therapeutic conversations, literally influencing brain wiring and function.
It really is.
Okay, let's conclude with what the text calls the final exciting frontier: psychedelic-assisted psychotherapy.
Yes, this is a novel and, well, very promising paradigm, although the studies are still in relatively early phases compared to other therapies. Clinical trials using substances like MDMA for severe PTSD are showing some powerful results. It seems to foster deep connection, trust, and mutual empathy, sometimes dramatically so.
Yeah, and they're even exploring it in couples therapy.
That's right, conjoint therapy. Additionally, trials using psilocybin, the compound in magic mushrooms, for things like alcohol use disorder, have demonstrated pretty positive results, showing significant reductions in heavy drinking days compared to placebo groups, even in long-term follow-up.
So a lot happening there.
Definitely an area to watch.
Okay, so what does this all mean? We've covered, gosh, everything from 19th century theories of the unconscious through highly structured modern behavioral models and now into 21st century neurobiological modulation and even pharmacological assistance. It's a huge landscape.
It really is.
Yeah.
And I think the material emphasizes that knowledge is most valuable when it's understood and applied. Regardless of the specific modality, whether it's deep psychodynamic exploration, or ACT's focus on commitment and values, or MBT's focus on reflective capacity, therapeutic efficacy ultimately seems to rely on these shared, patient-centered principles.
Principles like
the strength of the alliance, providing corrective emotional experiences, instilling hope. These common factors we talked about at the beginning, they seem to be the anchor.
Which brings us back to that initial point. Given that the therapeutic alliance, the relationship, is consistently shown to be as critical as the specific technique applied, maybe should we, as patients or practitioners, focus less on finding the perfect technique and more on finding the right fit? You know, that shared mission that drives mutual progress and maybe even prevents burnout. It seems the human relationship itself might be the most powerful factor we have.
That's a fantastic question to carry forward, I think. In a field this diverse and rich, recognizing the power of that alliance really means that the learning and the potential for healing is truly a shared endeavor. It's built on curiosity and trust. Thank you for exploring these complex systems with us today.